that is happening in Italy. Data science for health is a hot topic all over Europe. So it's great to see that you are pioneering this one in Italy. I personally live in Finland, and this is what we like to do in Finland. We like to carry children on frozen lakes. Now look at the joy in my eyes and in my child's eyes. But apart from these and other things we love is data. And the country has been collecting data since the 70s. There is a sort of passion to collect data in every aspect of life because there's a lot of trust in the government and because we believe that by using data we can take informed decision, informed political decision and social decision. I personally love health data. I like to collect as many as I can. I like to aggregate health data from different sources. And thanks to God, the government came in help to my sort of addiction. Back in 2019, there was a rather revolutionary legislation that came to play. This was called the Act of Secondary Use of Data and Social Data. Now, this is important. You already know that in the Nordic country, we're good in collecting data, but this did it even better. Before, you had to go to different data holders. So imagine you want some data from hospitals, some other from the tax agencies, some others from a governmental agency. You had to go and knock each door of each this institution and ask for data to be connected to each other, for example, for research and innovation purposes. This was a time-consuming activity. It was possible, but it was time-consuming because you need to know all the procedure to get the data from the different data holders. And so what has been done after 2019 is to create a single stop-shop agency that does this job for you. And he also maps the data that are available across data holder, both in the health and welfare space. So you go to this agency, which is called FinData, since everything needs to start with Fin and then something attached. You just go to this agency, you ask them for data, and they do the job to go to different data holders, take the data for you, put in a secure computing environment, and they check that the reason why you access this data is consistent with legislation and regulation. So this has been a big change. And this change has now been taken over by the European Union. And many of you know that United States innovate, China imitate, Europe make legislations. That's more up what's happened here, but I think he did it well in the sense that he regulates by imitating actually pretty good law from Finland. This is an act, and when you see act, it means that this needs to be implemented by all the member states. It's not something that is optional. There is a mandate. And so the act came into place, I think a week ago, officially. And there is the first deadline for implementation will be, I think, in 2027 and up to 2022 for other part. Why this is important and why this is going to transform the data access, not only in the Nordic country, but also in Italy. As all of us are sort of producer of data, right? Some of us are patients, and we do that by sort of giving our data when we get in touch with the healthcare, for example, a hospital. These agencies that get the data are called data holder. They hold your data, right? And currently it's difficult to get to a data holder and say, I want this data to do research, for example. So what this act, among other aspects, is doing is creating a national access body. In Finland it's called FinData. In Italy will be another agency, which allows to access these data for specific purposes. And so this data user that you see on this side, they can be researcher, but can they be also company, so innovator. So this is push innovation, startup. And they can go to this agency and get access to different health data that are mapped. Now, there are some, I think, important aspects to consider. The first is the definition of health data. Now, it seems simple. I think every one of us thinks, what is health data? Would you think like income is health data? Well, so income is often the strongest predictor of health outcomes if you look at most of diseases. And so this legislation actually look at information as social determinant of health. So socioeconomic information as health data. And so they can be mapped, they can be connected with health data. I think this is extremely important if we think about studying fairness in algorithmic, and I will show you later. There is a clear purpose of the use of health data. So as I mentioned, is research contributing to public health, but is also innovation. So companies are not excluded by the access of health data. And then there is the establishment of this national agency. So how do we safeguard the privacy of each citizen, right? Because this is important. What the legislation does is using an opt-out approach, which is, I think, a fair compromise, which means you don't need to give a consent for your data to be used for this activity, but you can easily track how this data is being used for your activity, and you can opt out for the use of this data for your activity. And this will make this data much more accessible, especially in Southern European countries where there is a difficult interpretation of the current legislation. Okay, but this is kind of a scientific meeting, so I stop with my lawyery things, but I think this is kind of transformative. So what you can do when you have all this data together, right? You can do things like what we have done now some years ago in Finland, which is bring them all together. This project is called Sphere Registry. We take the entire Finnish population. Actually, we take more than the entire Finnish population, which is around 5.5 million people, because we take also everyone that is not alive anymore, but was relative of people that are alive, so that's bring around 7 million people. And we really map register across many different domains of health. So we have data that come from the hospital, from the cancer registry, from birth registry, infectious diseases, every medication that is purchased in the country, but also demographic and socioeconomic information, for example, pension, social assistant, earnings, so for example, income. This gives us more or less a sort of a metrics, if you like to think it in algorithmic terms, of around 6.5 billion rows, where each row is an event that happened to your life when you get in contact with the government through agency or through hospitals. And I think we have a winning point here in Europe compared to some of this effort done in the United States. This is that we see people also before they get sick. So we have a well-working occupational health care. And so it was kind of shocking to me to know that around between 2014 and 2022, around 91% of all living Finnish individuals have at least one lab measurement recorded, which is now in this database. And this happened because you often go to the doctor, even if you don't need, if you're not sick, just to check your lab values to see if everything is good. And so this is really important because it allowed us to build models that can be used to prevent diseases rather than check diseases one they happen. And so I like to think about sort of this data as like stories. Each of us is a sort of a sentence in a book, right? We have this big book called Sphere Registry, and these are sentences, and all together they create a story. Right? And these sentences are not disconnected to each other, but they're actually connected in many reasons. One reason is to pedigrees. So we have this multi-generational registry where you can see who is the mother, father, and children of the different people. So we have this connection of stories. We have doctor-patient relationships. So we have information who is the doctor and who are the different patients. And by sharing the same doctor, you share, in a sense, a common story, and we can look how event in the life of doctor might impact the patient outcome. But probably the first things you can start to do when you have sort of this book of stories to do something similar to what Google Ngram Viewer does, right? Do you know the Google book Ngram does is basically track the frequency of words over time. So we have done something like that for every single disease in our database. We had defined around 1,000 different disease endpoints. And if you go to this portal called resist.finregistry.fi, you can actually look at the distribution of all these diseases over time. You can see the prevalence, the frequency, you can see the relationship that exists in different diseases. So if you're diagnosed with one disease, what's the risk of being diagnosed with another disease? And recently we have added information about laboratory value as well, because we have this new database that tracks the entire laboratory value in the country. So if you can look at the distribution of C-reactive protein in the population, you can look there and look at the distribution of this lab value. So I think this is important, that when you have this massive data set, we extract information in aggregate form clearly, and we make them available to people, to other research, and this is what we have done with RISTIS. Now, you can do a lot of useful things. I will show you some useful things, some less useful things, but I think also quite fun ones. Something that you can do that is kind of useful once we had this database is that there was a new immunoprophylaxis for this RSV virus. RSV is the first cause of hospitalization in infants. Is a serious concern for a lot of parents. And there are new prevention strategies that are available, but you need to find which infant you need to give this immunoprophylaxis. And it's not easy because the infant don't have a lot of information. I mean, they are just born, right? So, okay, they are not all the same. Some they might have problems during birth, but what it matters is really the parents and their siblings, because we are thinking about virus. So what we could do, because we have these stories, we have this network, multi-generation register, where each one is connected to another, we could build a prediction model of severe RSV infection by using information from the relative of each infant. Right? And we have mapped more than 1,000 potential risk factors, not only from the infants, but also from the mother, the father, and the siblings. And when I say that this is useful, actually, after we published this model, it was taken over by the guidelines, at least in Finland, for who we should give these immunoprophylactics. Now, coming on some other more, interesting, or not more interesting, but also interesting area of research is I'm going to tackle two problems which I think are really important when we think about AI for health. Right? The first problem is fairness. We have this massive data set, we can build a model, and are we able to put out this data set? What's happened if we put out these models in the general population? Is it going to work good for everyone, or we are going to create even more inequality, right? This is the concept of fairness or algorithmic bias. And in this case, we go and predict in the entire Finnish population something maybe not super clinically relevant, but let's say very easy to measure, which is 1 year mortality. And we model this using approaches that are very similar to the one that I use currently by models that use text, right? So we treat, you remember before I told you that each life can be seen as a sentence, and in fact the model we use are models that have been designed for text. They take each word or each time event, and they model the sequential nature of these events. So here, what you see here is an individual, and at 58 years has a bunch of diagnosis and medication. At 59 years, he goes on and develops more diagnosis and medication, and so on and so on. And so we use in this case like a recurrent neural network, but we have used a transformer and other approaches to model the sequence of events. And what we do is what we predict 1 year mortality. So we use around 8,500 features, the model is around 2.9 parameters, so not so big if we think about language model, but quite big if we think about health data set. And one of the cool things when you start to use your entire digital fingerprint or footprint to predict mortality is that you can start to imagine this as a sort of digital marker of aging. So now you will have your 1 year risk of dying based on your entire footprint in this register. You can compare with your 1 year mortality risk using your chronological age. And the distance between the risk using chronological and all this data become a sort of digital marker of aging. Now, do we predict well if you die when, the mortality for the next year? Yes, we do it quite well. It's sort of the AUC is 95%, so it's quite high. Of course, we do well on predicting mortality just by using age and sex. As you can imagine, age is a pretty big predictor. So maybe this is sort of not so relevant. But when you control for age and sex, so you remove those effects, you see that the model is still very predictive. And now here our sort of baseline model is flat because we have removed the effect of age and sex, and this is what the model was built for. But instead, our recurrent neural network model, they use these all this wealth of health and welfare information still does quite well. And it does particularly well at younger ages, which is something that was surprising me in the beginning. But then I spoke with some people that work in the field of aging, and they actually told me that it's a well-known phenomena, which is it's easier to predict mortality in young individuals than in old individuals. And that's because sort of when you're young, there's no many causes of death and no many reasons why you die. When you get old, there's much more entropy, right? So once you control for age, it is more difficult effectively to predict mortality in older individuals. And this is seen also not only with this sort of digital aging marker, but also when you think about epigenetic marker or other type of biological markers. But I think the interesting things that I want to focus here is about, okay, I go today with this model, I go to our National Institute of Health, and I say, I have a model that allows you to see who is dying next year, maybe you can do some preventive treatment, or you can do better allocation of fundings. Are you going to do that? And hopefully that person, when I go there, he will ask me, well, but what does it work well everywhere? Are we going to create more inequality if we do this type of strategy? And so we start to think about that. What you see here is a map of Finland, and the color here is how well the model works, right? Lighter color, the model works less well. Darker color, it works better. And you can see that across different regions in the country, the model has different performance in predicting one-year mortality. It does worse in the north, in Lapland, where there is also, the population is more sparse. And it does better in the south, but even in the south, there are regions where you see clear inequality. For example, these two that you see, they're close to each other. And might be, for example, because some of these regions don't report the data in a proper way. Now, we think about things that matter. We can think about socioeconomic status. One way to measure is income. In this case, we are using pension because most of the people die when they're old, and so pension is more relevant than labor income. And what you see in the graph here is that if you have a lower pension, so you're on this side, the model tend to work worse. So we do a worse job in predicting mortality than when you have higher pension, which is up there. While the model that is more simple here is just to sort of work consistently across all these different pension bins, but it doesn't work as well as the model with the recurrent neural network. And you can do this exercise across different categories. You can try what we call these sensitive and protective attributes. So you can take people that are married and non-married, immigrants and not immigrants, people with mental health diagnosis or with low and high pension. And you can see that these sort of AI models tend to work less well in generally the sort of sensitive protected group compared to the non-sensitive and protected group here. You can summon them, so if you're sort of across, you have more than one category, you are sort of across many of these different categories that are sensitive and protected, then you see that the model performances are substantially lower than if you are not in any of these categories. So there's a clear, unfairness results when you think about this model. But I think what is important here is that we can measure them. And when we think, for example, what's happening a lot in the United States, where they've been ahead of Europe thinking about these things, there's been a lot of focus on age, sex, and race, ethnicity. And often the reason why we have this focus is because that's the all information you have in the electronic health record. It's not necessarily because that's the things we should or we want to focus on. While in Europe, which we have the luck to have more of this sort of welfare and socioeconomic information collected at population level and linkable, at least in the Nordic country, we can now look at these AI models and really be able to go deeper in certain characteristics which we do not want to discriminate. For example, we don't want to increase socioeconomic inequality. So take-home message here is so far, these models are unfair compared to simpler model. This is sort of the negative aspect. The positive aspect is that we have tools to really understand where they work and where they don't work, and we should work with ethicists and legal scholars to really understand which are the categories where we don't want this model to do worse, because we think as a society that we do not want increase inequality in those groups. The second problem, which I think it's really important, is somehow related to this one in this sort of model for machine learning for health, is the generalizability of the model. So let's say we have solved the problem of fairness inside Finland, but we still need to take this model and maybe transfer to other countries, right? We want pan-European models. And we know that different countries use different healthcare coding system, and there are different doctor practices. So there are approaches, like we will all map to the same common data models. These models are called OMOP. They are used nowadays across European countries to harmonize the use of this diagnostic code across country. But that's not enough, because there might be different ways in which doctors assign diseases across country, despite they think it's the same disease, but they use different codes. This is an example, unspecified angina pectoris. Sort of the prevalence overall, if we look across all those codes related to angina pectoris, is quite consistent across the country. But if we look at exactly at the use of this code, which many of you will not say anything, but is one of these ICD code, there is a very different use in Finland, 4.3%, 60% in Norway, and 0.1% in France. And the reason is that simply there are, different coding attitudes by the doctor, right? But we use this data, we use this statistic to train model, and so we want methods to being able to harmonize this mapping of diseases across Europe. And so one approach here is to use large language model. Let me explain how you can do that. So imagine you have two countries. Up you have UK, so we're using data from UK Biobank, which is a large study. And down there is FinGen, which is in Finland. And what the doctor wants to diagnose the patient with is upper respiratory infection. But the way it codes those information in UK is using this code, right, which is acute upper respiratory infection up there, and down here is upper respiratory infection, okay? So they want to say the same, but effectively use two different codes. Now, if we build a model based on these codes, of course, the two models cannot speak to each other because, they don't recognize that the things mean the same way. They are different coding systems. So what you can think about is, can we use large language model to take the meaning of this code and mapping to the similar embedding space? And this is what you see in this illustration. So you can go beyond the use of the code by associating language to the code and using language rather than the code to build this model. So what we have done here is that simply use OpenAI language model and then use this embedding projection of the language associated with this code to train our model for predicting diseases. Just to give you a sense on how things look like, this is our old predictor of depression. And this is a two-dimensional representation of all these different predictors of depression. And some of these predictors of depression are seen only in UK, some are seen only in US. This Mount Sinai is a dataset from New York, or they are seen only in Finland. But they still cluster close to each other because they have a similar ontological meaning. I'm going to zoom on one of the cluster there. This has to do with substance addiction. You know that substance addiction is a correlate of depression. And you can see that the sort of these different drug dependency codes, despite being seen maybe only in one country, they cluster very close to other predictors that mean more or less the same things, but they are not seen they're seen only in one country. Now, I just want to show you that these models are not perfect, right? Here you see adult victim of abuse. That doesn't have to do with drug abuse or drug addiction, but there is the word abuse in it. And so the model or sort of ChatGPT, the LLM in this case, try to put this adult victim of abuse in this cluster of drug abuse, but this is clearly sort of a mistake. And there, we have approaches to go beyond that, for example, by mapping a sort of network structure between the different diseases. Now, the cool thing is that now you don't need to have the same coding system. You can just use language as a sort of universal way to transfer this code across country. So here is an example. So we are predicting the onset of all these different diseases, right? And this is how well we predict the onset of different diseases. In blue, if you just use age and sex. Here we are using the sort of the best approach. We go from OMOP to OMOP. So same coding system from UK to USA. We do quite well. But you see that we can use completely different ontology. Here we use OMOP to ICD. And we still do quite well, despite the coding basically never being able to speak each other by just going through these sort of embedding ontological text mapping. So these are sort of way in which we can think about using this language model to make the work more transferable. Okay, but so far I spoke about sort of what we call phenotype risk score. But I'm in a omics session, and so I'm just going to go also on some genetics, right? And in genetics, we use polygenic risk score to do prediction. So why do we care about genetics? Well, genetics, believe it or not, is cheap to measure nowadays, much that you think. I think $20, $30, you can have a good part of your genome, or the most important part of your genome available. So it is a cheap biomarker. It can be measured early in life, and it needs to be measured only once. And then it's somehow causal, right? Now, it depends on how you mean causal, but there's no reverse causation. So it is always something that is upstream of your risk of diseases and so on. So there are some fundamental intrinsic good property about genetic when we think about predicting health outcome or events. And so what we do, to use genetic for prediction is that we do this polygenic risk score. Polygenic risk score are a combination of many of these genetic variants into your genome into a quantitative score. You can imagine it's like normally distributed, and it's as any other biomarker, right? If you have a higher value of this biomarker, it tells you that you have a higher risk of diseases, and if you have a lower risk of disease. And we have been really good in building polygenic score, not just us, the entire human genetic community, so much that now we can really do it across many different countries. And so we have done it in these European consortia. We have done it across 4 countries, 7 different studies, and we can look at the association between this polygenic score and diseases at a large scale, because these are all biobank connected with electronic health records. But we can go beyond just providing relative risk. So what's your, increased risk, your twofold increased risk if you have this polygenic score? We can now sort of calibrate this model to the prevalence of a disease of population level. In this case, we use global burden of disease. So we can really take something genetics, which has been a lot of use in research in a sense, and give metrics that are really relevant for public health, that can be understood by public health officials. First, one thing to mention, polygenic score, not just because they are sort of, you have it at birth and they are genetic, they tend to have an age and sex specific effect. In particular, they have an age effect. So they tend to be more predicting among younger individuals than older individuals. This is not surprising, because we know that genetic is somehow more important at younger ages than older ages. And this is because at older ages, for the same disease, we accumulate a lot of other risk factors. So, if you are young, you have not so many other environmental exposure that might contribute to your risk of disease, but your genetic tends to have a predominant role. And you can see it all across all these diseases where the effect size tend to be larger here among the younger individual, here in this lighter color compared to the older individuals. So we need to model this aspect as well, the age and sex-specific effect. But after we have done that, we can sort of draw these beautiful curves And what these curves say is sort of your cumulative lifetime risk of developing, in this case, type 2 diabetes, given your polygenic score, right? So each of us is on one of these lines. 1% of us will be on the sort of unlucky line up there, and 1% will be on the lucky one here, and the other are in the middle. And you can see that if you are on the let's call it unlucky red line here, you're going to reach that threshold of risk that is consistent with screening for type 2 diabetes at 26 years of age, while if you are on this line one, you actually might never not reach it. And so when we think about who we should screen for diseases, which people should be more in contact with the healthcare, then polygenic score are an important tool for these purposes. Now, they're not the only tool. You can draw this line using other many risk factors, but there are some properties which I mentioned before. They are cheap and they can be measured early in life. So this is the use of polygenic score for screening, yeah, right? So you don't have the disease yet. You use this genetic marker to understand what will be your risk of disease in the future, and if you're on high risk, you take some action. Now, they are useful for some diseases if they're common enough, right? If you think about cardiovascular diseases, you can get statins. For other diseases, we do not have so much preventive treatment, like Alzheimer's, if you think about it. So maybe telling people that are on high risk of diseases is not actually a good public health strategy because we know really much we can do. But we can keep monitor people. So the other opportunity to use genetics beyond sort of screening is think about treatment, right? So can we use genetics to find a group in the population where the treatment works best? And in this case, statins, which are one of the most common preventive treatment for, in this case, for cardiovascular diseases, have an effect that it depends on the polygenic score. So this is a study from 2015. So at that time, we didn't have so powerful polygenic score. I think we should redo it now with more powerful one. But you can see that the effect of statins on cardiovascular diseases is lower on people with low polygenic score for cardiovascular diseases than in people with high polygenic score for cardiovascular diseases. You see this clear effect, indicating that if you have a higher polygenic score for cardiovascular diseases, you have better response to statins. And this is useful for many reasons. One of these reasons is that they help you to design better clinical trials. And when you think about the clinical trials, especially clinical trial for diseases like cardiovascular diseases or primary prevention of cardiovascular diseases, nowadays these trials are very, very expensive. And because they are so expensive, there is a sort of many pharma companies are deciding not to start new trials because the investment is not worth it. And so there need to be strategies to make this trial more effective and more cost effective. And one way is to use this polygenic score. And you can do it in two ways, right? You can do this sort of prognostic enrichment. So now you take a population with high risk for cardiovascular diseases, or you can do predictive enrichment. So now you take a population where you have higher response to treatment. And people have done this type of analysis and have shown that you could have run these trials. This is a PCSK9 trial, more recent medication for cardiovascular diseases. If you would have recruit people using genetics rather than just other selection criteria, you could have reduced the sample size of the trial from 27,000 participants to around 2,300 participants. And you can do that, and you keep the same statistical power, but you reduce effectively the sample size. So this is a good way to use this polygenic score beyond sort of the screening. But now, of course, you need to design a new trial, right? You cannot just run trial and see if this polygeny works or not. So how can we start thinking about testing this future trial that we have not run yet, but we want to run? How do we test it using the data that we already have now? And this is what is called trial emulation. It's a sort of gold standard in pharmacoepidemiology nowadays. In the randomized control trial, you take people, you randomize to a treatment or a control. In the trial emulation, you take observational data, for example, those nice data set like Finland registry that I mentioned before, which have a broad coverage of health data, or you take electronic health record for your local hospital, and then you emulate this randomization by doing matching. So in this case, you do propensity score matching. You try to remove every possible confoundings and to almost have two groups that are randomly assigned a treatment. We have done that in Finland, in our biobank, FinGen. So now this is not the full population, it's a subset of the population of 500,000 individuals for which we have genetic data. And so now we can emulate trial inside our biobank, but we also have genetic, right? And so we can test how well genetics can work for this prognostic and predictive enrichment. We have done this for trials. These are all very important cardiovascular trials that have been published in the literature. In this case, we are using existing trial and not doing completely new trials because we want to see if our approach is working. And you can see here, these are sort of the other ratios that you get from this trial. This is sort of the published trial, and this is our emulation results in our biobank. So we do quite well. We sort of have effect comparable to the one of the original published trial, where we really randomized people, not just statistically randomized people. And when you look at this sort of prognostic enrichment, you see in this case that for some of this trial is working. So for this cardiovascular trial, MPAREG and TECOS, using polygenic score, we'll have reduced the sample size of the trial of around 8.6% for MPAREG and 26% of TECOS. But when we look at the other trial, which outcome was stroke, you see that this doesn't work, right? The effect here, this polygenic score, do not really associate with the outcome of the trial. It does associate in the general population, right? So when you just test your polygeny in the general population, it's working. But now when you have emulated trial and you look inside your emulated trial, the polygeny score doesn't work anymore. And this is an example why it's important, before claiming that polygeny score can be used for predictive or prognostic enrichment, that you probably want to try to first emulate your trial, see if it works there, and then maybe spin off your trial in the future. Now the question is, why it's not working specifically in this population? We don't have a super clear answer, but probably it's because the inclusion-exclusion criteria shift the risk distribution in the population. In this case, these are people that have atrial fibrillation, which is a higher risk factor for stroke. So these are people already on very high risk of developing stroke. And this polygenic score is less predictive of stroke because sort of the risk that you can explaining is limited. So you sort of compress the variability by using inclusion-exclusion criteria in the trial. Okay, now another cool stuff that you can do once you have genetic in emulated trial is to do better emulated trial. So traditionally, you take these observational data, you emulate your trial in observational data, and you try to adjust for confounding. And you can adjust for confounding if you have measured the confounding, right? And you might have a very rich data set that has a lot of covariate that you can use for matching. But what if you don't have them, right? And you have genetic instead? Well, with genetics, you can build polygenic score basically virtually for any disease for which we have done a genome-wide association study. So you can use a sort of this polygenic score as a sort of tool to test how well you are emulating the trial. Now here is what's happening in the distribution of this polygenic score between the two arms of our emulated trial, if you just use a very naive approach. So purely observational data, we don't try to do any inclusion-exclusion criteria, we don't do any matching. You see that the polygenic score are very unbalanced. So there is a difference, here is the difference between the two arms of the trial. And here we're looking at a bunch of diseases and sort of potential risk factor. So there's a lot of unbalance on this polygenic score. But then when we start to go in the direction from plain observational analysis to more trial emulation, you can see that these things are getting close together, so less and less different. And here you see almost no difference anymore after we had done this sort of propensity score adjusting approach. So the first things you can do with genetics is to understand if your confounding adjustment in your observational analysis is working in this trial emulation. Then it comes natural and asks, wait, okay, so I calculated all these polygenic score. Can I use them to do better matching? So not only to monitor if there is a difference, but I take this polygenic score and I put in my model as matching covariate, sort of matching on genetics, right? This sounds kind of a natural approach, but it actually doesn't work. And I think maybe this plot doesn't tell you exactly that, or is not so intuitive. But what's happened is that these polygenic scores are predictive of the potential confounder you want to adjust for, but they are not 100% predictive. They're weak predictor. And so what you're doing if you adjust for a polygenic score, you're adjusting for a very weak predictor of the confounder that you want to adjust for. And this sort of doesn't work as an idea. But you can do something else than using polygenic score. You can use Mendelian randomization. I'm not going too much in detail here. I think maybe few only can follow at this point. But this Mendelian randomization uses genetic variants to as a sort of instrumental variable. And you can use these Mendelian randomization genetic variants as instrumental variable for the confounder of your analysis. So you have a way, a sort of causal inference way to understand what can be a potential confounder in your model. It's a sort of confounder detection approach that uses genetics. This is cool because, again, it's difficult to understand what is a confounder or not. And also you need to have measured that confounder. But with genetics, you don't need that. You can use this sort of instrumental variable here, G, to try to detect confounder that, that impact the association between X can be your treatment and Y can be your outcome in your emulated trials, even without having measured in C, just by using this approach. Okay, so I'm going to conclude the talk here by bringing the two aspects together. We have seen in the beginning this phenotype rescore, and now this polygenic rescore. So are they the same things? Do they explain a different aspect of prediction of diseases? What we've been doing is we've been comparing head-to-head these two approaches. So predicting diseases using genetic and predicting diseases using electronic health records. We have done that for 13 different diseases in 3 biobanks. And now PRS you're used to is what we call polygenic rescore, is the genetic part. Now we call the phenotypic prediction, so using the electronic health record, we will call it PRS, which stands for phenotype rescore. Apologies for the name, I didn't invent it, but that's it. So we have PRS versus PRS, right? And we want to see which one does predict better onset of diseases. Polygenic score you have from birth, so the study design is relatively simple, right? You was almost looking at the risk for birth, but when we look at PRS, we need to extract information from your past medical history, and so we need to take a sort of observation period, and here we are using 10 years, in this case from 1999 to 2009, we leave some washout period, and then we predict the onset of these 13 diseases between 2011 and 2019. And in this part, we build the PRS, and from birth, we have the PRS. So in this plot, we are comparing how sort of associated are PRS and PRS with these different diseases. Down here, you have the hazard ratio for one standard deviation in the polygenic risk score, and here you have it in the PRS. If you are on this line, they have the same effect. If they are below this line, means that the polygenic risk score works better. If they are above this line, means that the PRS works better. Now, you can notice immediately that for cancers, the genetics, so the PRS, is more predictive than the polygenic risk score is more predictive than the phenotype risk score. While for diseases like depression or asthma, for example, you have the polygenic risk score predicting more. Lung cancer here is an exception. You can guess why. It's smoking, really, that come here. This is sort of something I would have expected, like cancer are less socioeconomic stratified than these other diseases. So cancer sort of hits everyone, and probably you get cancer even if you don't have a long history of information in your electronic health record. While when you think about depression, there's a lot of comorbidity that come off with depression. There's a lot of socioeconomic correlates. And so the fingerprint in your electronic health record is much more heavy for things like depression. And so you can predict better depression using your electronic health record than genetics. Small point, not so important, but if we look at high-risk individuals, you can predict better with the FRS than the polygenic risk score, just because these FRS have a certain distribution which is not completely normal. There are some risk factors which are, much stronger in the FRS than the PRS, than the polygenic risk score, and if you have those risk factors, then the effect is much higher. But this is just a nuance. Now, the big question is, are the two the same, right? So shall we use one or the other, or we should use both because they are complementary? And again, here you see on this line the association between FRS and PGS, adjusting for the other. So putting in the same model PGS or putting in the same model FRS. Well, the take-home message is the effect doesn't much change, meaning that predicting with FRS and then adjusting for PGS or adding PGS does not change the association of the FRS with the outcome. And this is the correlation between FRS and PGS. Look here at the scale, it's very low. So the two information are rather independent. So I think that it's more or less like this. It's a happy relationship between the two. Okay, so some take-home messages. You need a forward-looking legislation. It's not so much having a lot of money or having the smartest people in the world in a place to make some of this science successful. And this is something maybe I realized later in my life, but it's important to have the legislative landscape and framework, especially when we think about using health data to make this type of approach is successful. And I think the European Health Data Space Act is really an opportunity for Italy and for many other places to open up this health data on a scale that was not previously possible. And I hope many of you will just, get access to this data and be able to work and create amazing algorithms and model on this data. We need to think more about fairness. I think this is sort of understudied when we think about this AI in health. And the reason why we can do fairness is that if we have the data to study fairness, it's not just our willing to study fairness, but it's the ability to link this health data with socioeconomic information. And so we need to open up this linkage between these two types of resources. We're going to always have the problem in Europe and within country. Italy is a big country where there's going to be this problem of transfer this model. They will work well in a hospital. They will not work well in another hospital. One way is that we try to have everything harmonized to the same model. That's sort of the top-down approach. But there can be like some bottom-up approach where, this innovation, for example, this large language model can come and help with that. Genetics can be used for causal inference, and it's not reverse causation. And I think what I showed you before is that you can use genetic to design better epidemiological analysis to adjust, to understand what are the potential confounders without actually measure for confounding. So genetics is not only a predictive tool, it's also a statistical tool that you can use as one of these other tools that you can use in your statistical models with the specific property that it's sort of some good property for causal inference. And then finally, when you have both genetic and electronic health records, use both because both are complementary and both are predictive. So thank you very much. This is my team that has done most of the work, so big thanks goes to them, and thank you for listening.
Thanks, Andrea. Really fantastic talk, overview from the legislation to the genetics, going through the electronic health record. So we have some time for question. So please raise your hand and we'll have a microphone. I'll maybe start with one question. You discussed about fairness of electronic health record. One of the challenges, I guess, would be good to get your idea, is really about the access to healthcare. And so how does it impact in terms of fairness of electronic health record? In Finland, probably the majority have access to healthcare. In other countries, this is different. How do you see the problem and how we're going to tackle this problem?
Yeah, so of course, if you've never been in contact with the healthcare, the model is not going to work very well. But we were surprised. It's not a one-to-one relationship. It's not how rich is your electronic health record, then in that population the model will work better. Because if that will be the case, then we will predict better in those groups that have lower socioeconomic status, because normally people with lower socioeconomic status tend to be more in contact with the healthcare. So the electronic health record system is more rich than people that are more wealthy and healthy. Still, we predict worst in that group. So I think that's a problem. Of course, you have less data, the model will work less well. But it's not as simple as I thought. I think that was one of my thinking. We will do well among people that have been a lot to the hospital because we have so many information. But it turns out that was not so simple. Yeah. Wait a moment. Yeah.
Again, on the subject of fairness and using the PGS scores to create inclusion-exclusion criteria in clinical trials, do you see potentially this as a way of excluding people who may want to be on trials but don't have the right PGS score? Or, once the drug is approved, denial of access to people with the wrong PGS score because they weren't tested in that group?
Yeah, it's a good point. We had a workshop with some pharma company a few months ago discussing exactly, can genetic score be used in design of the drug? I think there are many different models. Of course, a concern is, from sort of an ethical standpoint, is yours. From a pharma standpoint, is like, well, now I'm restricting my patient population. Are going to make less money because I can give it only on people with high polygenic score. But they are sort of, and oncology has been really ahead on this. They are designing where you can use polygenic score as a starting point to make your trial more powerful, sort of a statistical tool, but then you can extend the use of the drug beyond that specific inclusion-exclusion criteria. For example, you can have a larger recruitment in your trial based on polygenic score, but you still keep some people that do not have that high polygenic score, so you can have your approval of the trial in a larger population, but you still gain statistical power by enriching on people that are on higher risk. So I'm not too worry about that problem. I think there are sort of smart ways. And I think the ideas from both the pharma side and the patient side is that we want this drug to approve to as many people as possible. So
I would just add that my son, who is I would just add that my son, who is an oncologist and working in a phase 1 clinical trial group, found actually very frustrating that the inclusion criteria were usually so restricted that many of his patients who wanted to get treatment couldn't actually be recruited onto these trials. So it's just something to keep in mind.
Yeah.
Hi, many thanks for this interesting talk. So one of the slides you're showing that the machine learning performance is slightly different between different regions where the AUC is different. Do you think this is because of within population heterogeneity? And is it possible to overcome this issue by using meta machine learning to overcome and increase the performance of the model across all the regions?
Yes, I think it's possible to use approaches to make the model more equal. I don't know if you can really go towards a model that, I mean, you can have an equal model, but you're going to sacrifice some region where the model works very well. You're going to push them down to work a little bit less well to achieve equality across different regions. You can train also a region-specific model if you want, but of course, power become an issue, or you can take model and then fine-tune, recalibrate the model in one specific region. So there are many approaches, and it's a sort of a rabbit hole in a sense, because you can cut your pie in so many different pieces. Can be region, but what inside region, maybe you don't want people on certain socioeconomic groups to be discriminated. So what you're going to do, you're going to just build a model for every single groups. And I think there is what we are trying to do now is really involve ethicists and legal scholars to understand what are these characteristics that we need to look at. And I think the AI Act now mentions some of these things, but it mentioned very general, say age, gender, race, ethnicity, things like that. But I don't think we have a real framework that, we know exactly which characteristic we do not want to discriminate to, and what as a society, we agree should be the most important things, beyond what everyone says just because what's the data that they have, right?
Good. Any other question? Yeah.
Yeah, thanks. This is a very interesting discussion. So to follow up on this, I guess what I found a little bit frustrating is that we really don't understand why the model is unfair. So I was wondering if you have some hints on how to go about that question, and whether that could be a way to maybe design a more fair model in the future.
Yeah, I'm with you. We went down to the rabbit hole. We tried to match exactly for number of cases. Then we tried to match by age and sex. We try, to make it as comparable as possible to see if that was the cause. And I don't think we have it super clear why. What we're trying to do now in the next project is doing across multiple countries and have all these different and see if it's something structural to the healthcare or is something more general. So, for example, if we see that in that specific group, the model works worse, both in Estonia, in Sweden, and in Finland, maybe something more fundamental. But if it works only worse in one of the countries, maybe it has to do more with this sort of the way the healthcare system works and record this data. But fundamentally, you need to act on the outcome, probably. So you need to say, no matter what, we do worse in this group, let's push it up or push the other down, or recalibrate the model. I think that's probably what we need to think for. Although it would be fascinating to understand exactly why. I agree.
Good. Final question from.
Hi, Andrea. Great talk. So you showed us how to use like health records, right? But how much do you think you can expand on it? Like use supermarkets, shopping, and people are taking picture of the food, and there's smartwatches. And where do we draw the line where at one point we're just getting too much information about people? Because I studied food a long time, and it's super frustrating. You cannot measure it.
It's a good question. So smartwatch actually are under the legislation. So theoretically, according to the legislation, you can demand company connecting smartwatch to get their data out for research. Of course, many they don't collect your social security number or your codice fiscale, so you cannot connect it with many other data. I don't think that there is necessarily a limit if you have the reasonable reason to do that. Supermarket, we have tried actually. There is, with some of our colleagues, we have a chain of supermarket that is very big in Finland, and when you register, you give your social security number so you can extract some of the data. But I can tell you, working with companies is complicated if they don't see an immediate reason. And so that's why it's important to have a legislative framework, because if they need to do it by law, not just because they see an immediate commercial interest in doing that, then they are motivated. And, Meta, for example, after some EU legislation, now you can go and there is an API for all the Instagram and all these things, which actually is amazing, works really well. And that's something that they didn't have until EU imposed them to have that type of API system for researcher.
Excellent. Well,
thank you so much.
Thanks again, Andrea. And so we'll now have a coffee. So I think be back at